From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to this JAMA podcast. Today we're joined by Dr. Carolyn Crandall, professor of medicine at the David Geffen School of Medicine at University of California, Los Angeles. Dr. Crandall and colleagues just contributed a JAMA review on the management of menopause. Welcome, Dr. Crandall.
Thank you for inviting me.
Let's start by having you explain to our listeners how most women experience menopause.
Well, that is such an interesting question because there is no such thing as a quote unquote normal or average experience of menopause in essence. Every individual tends to experience her own individual pattern of symptoms and patterns of changing periods, menstrual periods. A big part of caring for women who are going through the menopausal transition is actually the reassurance that this is a highly individual experience.
People commonly recognize hot flashes as a symptom of menopause, but what are some of the less commonly recognized symptoms of menopause?
So it's true that hot flashes are the symptom that people think about in association with menopause, but there are some women who will have night sweats and not have hot flashes, or they may have a combination of both. Some experience such a smooth transition that they don't really have any hot flashes or night sweats, but rather what they notice most is the change in their menstrual period pattern as being sort of disturbing or unsettling. The other constellation of symptoms that is definitely linked with menopause is what we call the genitourinary syndrome of menopause. We abbreviate this GSM. That's a complex of several different symptoms that include dyspareunia, so pain with intercourse, vaginal dryness, vaginal burning, vaginal pruritus, dysuria, urinary urgency, and recurrent urinary tract infections. So a woman may have more predominant hot flashes or night sweats or both, or she may have more predominant GSM symptoms, genitourinary symptoms, or she may notice that she's feeling fine, but she's having this change in her usual menstrual pattern that is what's signaling her approach to the menopause, to the final menstrual period.
In the review that you contributed for JAMA, you highlighted some of the major randomized trials examining the safety of hormonal and non-hormonal treatments in menopause. Please share with our listeners an overview of some of the key trials that are informing modern menopause care.
There are many trials, randomized clinical trials, that inform our knowledge, but really the key one, which is the largest study population, would be the Women's Health Initiative hormone therapy trials. And that, as far as we can tell, remains the only large randomized clinical trial to really look at breast cancer and cardiovascular disease and venous thromboembolism as a key part of the study design. And so it was actually designed to do that. So it's probably 10 to 100-fold bigger in terms of the number of participants than the other key clinical trials that we mentioned here in the article. But that particular set of trials, the Women's Health Initiative, was really focused on women who were already postmenopausal. So some subsequent trials that we talk about in the paper involve more recently postmenopausal women. That would include then the Kronos Early Estrogen Prevention Study, otherwise known as KEEPS. And also there is the ELITE trial, which is the early versus late intervention trial with estradiol. And then finally, one of the other key sets of trials, it's actually a set of trials called Ms-FLASH. It's a group of clinical trials that investigated several hormonal and non-hormonal treatments for vasomotor symptoms. And we haven't said, but we should say vasomotor symptoms is the term that we give to hot flashes and or night sweats.
What should clinicians know about testing that is necessary to determine menopausal status, and what tests are actually discouraged in routine clinical practice for this purpose?
This is so important, the idea of whether, when, how to do tests in women who feel like they're in the menopausal transition. It is a really common scenario for patients to come in and say, I would like to know if I'm menopausal. And so clinicians encounter this a lot. But quite honestly, the diagnosis of the menopausal transition is actually based on what we might call clinical horse sense, meaning it is adequate to consider the person's age and menstrual irregularity. And if they seem exactly like in that age range that we would expect for the menopausal transition to be going on, and they're having these typical symptoms, that is, vasomotor symptoms, and they're in that right age range, that's enough to make a diagnosis of the menopausal transition. Now, that said, we want to remind clinicians that women who are in that transition, they can intermittently ovulate. And so pregnancy testing may be important, and counseling women regarding that potential possibility is probably important. But we do not recommend measuring follicle stimulating hormone concentrations in women who are in their 40s to identify the menopausal transition. So that should not be routinely done. And the reason is because those serum FSH concentrations vary during the menstrual cycle. They vary from menstrual cycle to menstrual cycle. They vary throughout the perimenopause, and they don't even stabilize at what we would call a postmenopausal level until 3 to 6 years after the final menstrual period. And of course, by that time, you already know that the diagnosis of menopause is already apparent, because the diagnosis of menopause would be 12 months of amenorrhea in the absence of other causes of ovarian cessation. So we want to reiterate that measurements of serum FSH and estradiol concentrations are not indicated to diagnose menopause or to adjust estrogen therapy doses or to predict the menopausal transition or following bilateral oophorectomy. You would not do those tests in a routine clinical practice. Now, if you're not sure what's going on, certainly a gynecologic consultation might be recommended in those special situations if you're evaluating infertility or you're suspicious of menopause before age 40.
That's very helpful, and I think will give our listeners some excellent clinical guidance. You touched briefly on estrogen therapy, but let's look at the broader topic of hormone therapy. So menopause hormone therapy has been informed by some of the key trials you discussed earlier. What are the current recommendations for menopausal hormonal therapy?
So the primary indication for menopausal hormone therapy, and that would be either oral or transdermal therapy, would be to give relief of moderate to severe vasomotor symptoms. Now, we say moderate to severe, that is not based on some particular single number threshold. That determination of whether these symptoms are moderate or severe is based on each patient's assessment of how bothersome those symptoms may be or how much those symptoms interfere with the daily activities. So that has to be individualized. That determination of severity, degree of severity of symptoms has to be individualized according to each individual patient. The second key point would be that because of adverse effects that may occur with menopausal hormone therapy, for example, an increased risk of venous thromboembolism or stroke, and in the case of combined estrogen and progesterone therapy, there's a slightly increased risk of breast cancer. Because of that, we really would only treat vasomotor symptoms with hormone therapy if vasomotor symptoms are bothersome. Of course, we use logic as we do with other clinical prescribing, where we want to recommend the lowest effective dose for the shortest duration that would be consistent with the patient's needs, and we would periodically reevaluate the need for continuing therapy.
So it doesn't sound like there's much of a role for using menopausal hormonal therapy for prevention of chronic symptoms. I believe the U.S. Preventive Services Task Force has provided a recommendation on this. Could you discuss that recommendation?
That's correct. So we want to be careful to make a good distinction between women who have symptoms and are being treated for vasomotor symptoms that are moderate to severe, where hormone therapy is often reasonable, versus a prevention of chronic disease. And it is the latter, the prevention of chronic disease, that is addressed by the United States Preventive Services Task Force recommendation. USPSTF recommends against the use of hormone therapy for prevention of chronic conditions in postmenopausal women. We want to think back actually about the history of hormone therapy. At the time that the Women's Health Initiative trial started, actually there were many women in the United States that were told they should take menopausal hormone therapy in order specifically to prevent heart disease. And so our knowledge and understanding have greatly evolved since that time, hence the need for a careful examination of, is there a role for hormone therapy in preventing chronic conditions in postmenopausal women? And so we would say that the United States Preventive Services Task Force recommends against the use of hormone therapy to prevent chronic conditions in postmenopausal women. However, for the treatment of active symptoms that are moderate to severe of vasomotor symptoms, that would still remain the key indication now for using menopausal hormone therapy.
I suspect that many of your patients ask you about bioidentical hormones, and I don't know how you respond, but how would you advise our listeners to advise their patients about bioidentical hormones?
It's true, many patients are quite interested in the potential of using bioidentical hormones. First, it's important to understand what they are. So bioidentical hormones are hormones that have an origin from plants, animals, or chemical synthesis. They are identical to hormones produced by the human body in structure. They come in two forms. And this is the important distinction for patient counseling. The one form would be by prescription, meaning that they are FDA approved. And the other category would be what we call compounded bioidentical hormones. And the compounded bioidentical hormones are not regulated by the FDA for safety or effectiveness, and they're not monitored for quality. So when a patient says, I really want bioidentical hormones, what we should respond to is say, I hear what you're saying. I understand your desire to have something structurally identical to the hormones produced by the human body. Let me prescribe something that is evaluated by the FDA for safety and effectiveness. And there are several prescription therapies that have been evaluated that we include in our table. So there are estradiol preparations, numerous ones that are available by prescription that we list in the manuscript. And there's also micronized progesterone available. And then in contrast, as we know from a report from the National Academies of Sciences, those compounded bioidentical hormone preparations, those are not evaluated by the FDA for safety and effectiveness, and they don't have adequate labeling about instructions or contraindications or potential adverse effects. And we really don't have any reliable data to judge safety, efficacy, and product-to-product variability. In that case, we would need to inform patients about a lack of FDA regulation of those compounded bioidentical preparations. Instead, what we would want to do is use prescription FDA approved bioidentical preparations if a bioidentical therapy is what is desired by the patient.
And patients also ask what alternatives to hormone therapy are available. How do you advise your patients about the evidence for efficacy and safety of hormone therapy alternatives?
So the first thing in discussing alternatives to HT, to hormone therapy, is to make a broader statement to say that hormone therapy is the most efficacious in terms of reducing the vasomotor symptoms that people are having. That said, there are alternatives to hormone therapy for those who do not wish to or have contraindications to taking the hormone therapy. So some alternatives that we discuss would be SSRIs, selective serotonin reuptake inhibitors, and serotonin norepinephrine reuptake inhibitors. and gabapentin. Those would be some options. Now, we would say that paroxetine, just parenthetically, it's the only non-hormonal prescription therapy that has a specific FDA-approved indication to treat vasomotor symptoms. But on the other hand, venlafaxine is actually more commonly used for that purpose to treat vasomotor symptoms than paroxetine is. So often venlafaxine, we would say, is the most common non-hormonal alternative to treat vasomotor symptoms in terms of the prescription therapies. But other treatments, the selective serotonin reuptake inhibitors and gabapentin, have also been shown to be effective. So is paroxetine. And those will probably reduce vasomotor symptoms by about 40 to 65% in comparison to about 80% with estrogen-containing therapy. In terms of non-medication treatment of vasomotor symptoms, and some patients are disappointed to hear, we really don't have any treatments in terms of lifestyle and other non-medication treatments that are significantly better than placebo for alleviating vasomotor symptoms. So that would include, for example, acupuncture or relaxation therapy or phytoestrogens or exercise or black cohosh. Those are not significantly better than placebo for alleviating vasomotor symptoms. But that said, we should also keep in mind that placebo in itself, actually, there's a large placebo response to therapy in clinical trials of therapies to alleviate vasomotor symptoms. And so if you're reading the literature or your patients ask about some new therapy that seems to be effective in reducing vasomotor symptoms, it's important to emphasize that we want to compare with the placebo group. And in many of those studies, things like acupuncture, relaxation therapy, exercise, black cohosh, they turn out not to be any better than placebo in reducing vasomotor symptoms.
Let's turn now to the health risks associated with hormone therapy. Could you talk about what those risks are and whether there are any particular patient groups at risk?
Most of the safety data regarding hormone therapy comes from the Women's Health Initiative trial that I mentioned. And that trial examined cardiovascular disease and breast cancer and venous thromboembolism. And the dosage used was oral conjugated equine estrogen, 0.625 milligrams a day. That was given to women with a previous hysterectomy. And then in women who didn't have previous hysterectomy, who had uterus in situ, they received the conjugated equine estrogen, same dose, plus medroxyprogesterone acetate, 2.5 milligrams a day. So in that situation, we can see from those data that the conjugated equine estrogen containing therapy, that 0.625 milligrams a day, does increase slightly the risk of venous thromboembolism and stroke. And that is true whether it's given alone or combined with medroxyprogesterone acetate. And then additionally, in women who received conjugated equine estrogen combined with medroxyprogesterone acetate, that combination also increased the risk of breast cancer slightly compared to placebo. So that increase in risk of breast cancer was only seen in a combination group of CEE conjugated equine estrogen combined with medroxyprogesterone acetate. That's not a risk that is seen just with conjugated equine estrogen given alone. The reassuring part of this is that neither conjugated equine estrogen alone nor the combination with medroxyprogesterone acetate significantly increases the risk of coronary heart disease. And in fact, if you look at the absolute numbers for excess risk of venous thromboembolism and stroke with this conjugated equine estrogen containing therapy, the absolute excess risk is very small, particularly in younger women and those who are in the early menopause. And the same is true for the excess risk of breast cancer in women taking conjugated equine estrogen combined with medroxyprogesterone acetate, where that absolute increase in risk is quite small for breast cancer in younger women and those in the early menopause. In terms of other therapies, other than conjugated equine estrogen that was examined in the dosage tested in Women's Health Initiative, unfortunately, we really have few randomized controlled trials that evaluated safety and efficacy of hormone therapy for vasomotor symptoms, specifically that enrolled women who had vasomotor symptoms. So if we look at what do we know about the balance of risks and benefits of hormone therapy among young postmenopausal women with vasomotor symptoms, we really don't have any large placebo-controlled trial that was designed with the proper statistical power to examine the balance of benefits and risks of hormone therapy in that younger postmenopausal women with vasomotor symptoms, that population. And so that is why we focus still on the Women's Health Initiative as being such an important source of safety data. One final important point in terms of clinical counseling that we do suspect, because of the transdermal route that avoids first-pass metabolism, we feel that transdermal preparations probably confer less risk of venous thromboembolism, especially in younger, recently postmenopausal women, and probably lower doses of hormone therapy than those used in Women's Health Initiative also help to mitigate the risks of taking hormone therapy.
Dr. Crandall, when a clinician prescribes the transdermal route for menopausal hormone therapy, is it important for them to include a progestin?
It's important that both women taking oral estrogen and also women taking transdermal estrogen, if they have a uterus in situ, they need to take a concurrent progestogen. And that is because the incidence of endometrial hyperplasia, even after just 1 year of unopposed oral or transdermal estradiol or conjugated equine estrogen, is approximately 30%. So even women taking transdermal estrogen, if they have not had a previous hysterectomy, if their uterus is in situ, they are recommended to take a concurrent progestogen along with their estrogen.
Dr. Crandall, thank you so much for taking your time and sharing your expertise with our JAMA listeners. We really appreciate what you shared today and what you taught us. This episode was produced by Shelley Steffens at the JAMA Network. The audio team here also includes Daniel Morrow, Lisa Harden, Audrey Foreman, Marilyn Furkala, Hannah Park, and me, Linda Brubaker, Senior Editor for JAMA. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks so much for listening.